Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. Okay, younger patient, mid-20s, history of an ankle fracture. It was open, posterior medial about 2 years ago. History of DVT on Eliquis. Kind of comes in as a referral that sounds like kind of a big disaster. Carries this diagnosis of a complex pain. So these are her x-rays. So trimalleolar ankle fracture. I don't have any of the injury films, unfortunately, but you can see she's got plates and screws everywhere. So how are you managing, counseling, thinking through this patient? Maybe it's a lot of the workup we discussed before, open ankle fracture, pain, arthritic changes, fibula is like probably not united. So I'm going to kind of assume that most of you are probably thinking that same kind of workup in terms of workup, maybe taking the hardware out. Are you guys taking the hardware out in a staged fashion in this case?
I would stage this every time.
Yeah. Bethany, you too? No, maybe she got kicked off. All right. So here's her CT scan, sagittal scan. So you can see kind of a lot of bone loss. See here if I can get this to play on the sagittal. So this is a sagittal. When you hear us talk about a sagittal cuts, this is what we're looking at, this kind of view from the side. The coronal is the one kind of straight on. I think these are probably the most helpful cuts. Anything you'd want to point out here, Jan, on those?
No, I don't think it's much helpful now as it would be, post hardware removal. Like this is just, I don't know. I often get one still, but I don't know how good it is for me.
Yeah. What are you looking for on the scan that you would be different on the after hardware removal versus before hardware removal?
Well, if I have to remove some bone, so I think many times when you take out the hardware, some of the hardware could be broken. You might be using a hardware removal set, trefines, and so forth.
Okay.
And so I think sometimes more bone, I can see the bone defects better if I'm planning something on a hardware removal scan.
Okay. All right. So this is after the hardware came out. I did not repeat the scan after the hardware removal. I had kind of made up my mind. I was going with the fusion.
One question here. Sorry, we have one question
Yeah.
by Mike. Staging because you see CT, because you use CT anatomic guides, seems like a lot of soft tissue disruption. So great question, Mike. For me, it's not about, you're right, it's another surgery and so forth. But I think when someone has an open ankle fracture, their rate of infection is pretty high and it could be indolent. And maybe that's why they went on to PTOA, which post-traumatic arthritis and like fibular non-union. So by taking the hardware out, I can get good biopsies, cultures, and so forth. And I know this surgery is going to take longer because to do hardware removal and then a good ankle fusion surgery, it's a lot of work in the OR. It's different in a way, sometimes different setup, but if it takes you a long time to get some of the hardware out that you needed to. So I think it's better just to kind of do two separate procedures. Yes, it's two anesthesias. It's a longer time for the patient. I totally get it. But I'm biased that I want to, just focus on like the ankle fusion or ankle replacement. So if I was doing an ankle replacement on this, I would do the same thing.
Yeah.
And then what's the timing for staging? If I'm going to do a fusion, it's a little bit faster than if I'm going to do a total ankle. If I'm going to do a total ankle, I want everything healed. Usually it's 6 to 12 weeks for total ankle. If I'm going to do a fusion, I'll sometimes just do it like within 6 weeks.
Yeah. I think that's what I did in this case. The other thing with the total ankle, a lot of times you're getting CT specific, patient specific guides. And so it takes a little bit of turnaround on that as well. So that's kind of the other timeline to consider. On this patient too, she's on an oral anticoagulant. She has a history of, I think she had a history of PE. And so that was the other part of the other reason I was like, well, if I can get the hardware out, I actually just operated through her anticoagulation. I kept her on it the whole time. And then I can come back and probably do something lesser invasive in terms of, soft tissue dissection, and keep her on that through her fusion as well. Which raises the question, Jan, what do you do with anticoagulation around elective foot and ankle surgery? Are you stopping it all the time?
If it's just aspirin, I don't stop it. If it's, Eliquis or something, I'll stop it for a couple of days
A
usually.
couple days, yeah. Yeah. So this one I didn't. And so then, went ahead after biopsy cultures, everything was negative. What's your approach in something like this? Are you going to go MIS on this case? And what's your role for bone graft? I mean, there's some pretty big defects there. And go back to the x-rays. So might be having some technical difficulties so this is the way I approached it. So I decided to approach this arthroscopic, and I used one of the ankle distractors. And because I was, um, fusing the ankle, I didn't mind putting a couple big pins into the tibia, into the talus, and use that to actually distract it. So use the ankle distractor to get my distraction. So it was able to do it without putting any straps on the ankle. And got in there, got everything prepped pretty well with the scope, and then preloaded my guide pins into place. So it's a little bit confusing, here. This would be what I would hope for. It's not always obtainable. Sometimes you kind of run into each other. So, but your home run pin is, I don't know if I'll try to annotate this so you can see. But that would be, right here. That's that home run pin. You kind of see that in the green. And then I have a couple of medial pins that I'm putting in under the red, here and here. And then I was able to get another one kind of coming from the front, which I'll put in yellow, coming this way, which I think would have been probably this pin kind of more laterally here. So I kind of can preload those guide pins into place before I put any bone graft into the joint. And that kind of allows me, so after I get it all prepped, I can kind of get it ready to roll. And then I will go ahead, put my graft material in, which you can see here. If you really want to make it look nice and tight for your surgeon, you can put a little bit of Omnipaque in there, and then it makes it really kind of fill up that space. Like you've really kind of compressed that together, which works really nice. And then I can hold it, and I can have my assistant or the resident advance the guide pins in and across the talus, as we did here. And then you place, exchange your guide pins for your cannulated screws. There was a moment I went through and I was using old school 4 or 5 cortical screws, and that was kind of fun to do, but that's kind of a pain to do. I got a question here. What type of bone graft? I think that's a great question. And in this case, I used some proximal tibial autograft. I think I mixed it with a little bit of Arthrocell just to increase the quantity of it, and then packed it into that space. Actually, I think it was not Arthro. It was something more injectable. The name is escaping me, sorry, but was able to inject that into the joint there, along with a little bit of tibial autograft, which was kind of a nice option. Allosync Pure, yeah, thanks, Aaron. And that it's something to injectable, so there's some different options when you're doing it this way. And these are post-op x-rays, and hopefully she heals. This is relatively early on, but this is the hope that we're going to get this ankle to heal up in a good position, which is so a nice option if you're in fairly neutral alignment.
So I got a question for you, Nick.
Yes.
Are you always using bone graft?
I pretty much always use bone graft. It's usually at least some autograft. Sometimes it's a little bit of proximal tibia, a little calcaneal graft, but I'm pretty much always using some form of bone graft. How about you?
Yeah, I usually will try to use autograft. I sometimes will use some allograft extender, but I try to at least have some autograft, whether from the proximal tibia. I will occasionally take iliac crest, but that's usually if there's something I'm like I need some, either a lot of bone or some bone defect. But
Um,
yeah, proximal tibia works great.
Yeah, proximal tibia is a good workout. Does it matter for you based off age of the patient, or their health history? Like, let's take it. Bethany and I were doing a case the other day, and it was a patient with inflammatory arthritis, so presumably immunosuppressed. Does that change how you approach your autograft, and are you adding anything different in those
Yeah,
cases?
usually I'll add something to it then.
Okay.
And then, the only time like sometimes I will not use autograft is an extremely obese patient.
Mm. Just
Just
because
because
it's hard to get.
hard to get. Yeah.
Yeah.
So, um, I mean, if someone, or if they have a total knee, a lot of these patients are
Yep.
old and they may have
Yep.
a total knee, but they're not,
Yep.
maybe not necessarily, if they're obese, they're not a total ankle candidate.
Yep.
And, I wouldn't go to crest just because, I mean, if you have to go through
Yeah.
several centimeters of
Yep.
pannus.
This is a really good question here. Brian asked, are you planning on an eventual takedown for a patient this young or fused for life? And then I think that maybe the follow-up question that I think everybody kind of wants to know is, what do you tell these patients for, long term, with the risk of adjacent joint arthritis? Doing a fusion in the patient this young certainly has some consequences. Jan, how do you counsel them in this
Yeah.
case, and how do you counsel them about possible takedown?
Yeah. So I tell them all about adjacent joint disease. I think that's key. Almost all patients will have it at 10 years, but they're, in my experience and the literature as well, supports that they're oftentimes not symptomatic, which is good. And then I will, in terms of takedown, I've never taken one down. Um, and the patients that I fuse, they tend to be patients who I think are not going to be good total ankle candidates. I try to save the fibula as much as possible now, but a
Yep.
lot of trauma
Yep.
patients you can't. There's just no way, like they may have lost it on the road or something like that. So, but I do try to do that a lot more now. So, like, one of my partners takes the fibula all the time
Yeah.
and has very excellent results, but he doesn't do total ankles. And so
Yeah.
I save the fibula just in case.
I'm going to make a t-shirt. It says "Save the fibula."
What about the subtalar joint? Do you like saving the subtalar joint?
I like saving the subtalar joint. Do you think that matters?
I don't know. I go back and forth. I do think patients who just have a isolated tibio-talar fusion do a lot better clinically than pan-talar, I mean, not pan-talar, but a hindfoot
Yeah.
fusion with tibio-talar
Hmm.
or subtalar. But also it seems to be a different patient population though, too,
Yeah.
that we're doing that on. So it'd be curious if if someone was just, you know, fusing both when they didn't really need to be fused, how they would compare.
Bethany, what are your thoughts on that?
I like to keep it at the ankle if possible. I mean, it's really interesting when you're doing that surgery. If you take a lateral and dorsiflex, plantar flex, some of those people have a ton of dorsiflexion through that subtalar joint. They'll book open in the back and really get a lot of motion there. So if you don't have to take it away, I wouldn't take it away. About taking the fibula, one of our people here takes the fibula all the time for their ankle fusions, and more often than not, that subtalar joint over time will slide out in valgus. So I think there is something about leaving that lateral strut. If I'm taking the fibula, I'm usually doing a hindfoot fusion, like a double hindfoot fusion, so not an ankle in isolation.
Yep, that's a great point.